Hello everyone. Topic of today's discussion is odontogenic keratocyst. So starting with the definition of a cyst, it is defined by Kramer in 1974 as a pathological cavity having fluid, semi-fluid or gaseous content which is not created by the accumulation of pus. It is frequently but not always lined by the epithelium. So to simplify it, a cyst is a cavity which may have fluid, semi-fluid or gas, any three of these contents, but it is not formed by the accumulation of pus. Mostly the cysts are lined by the epithelium and they are known as true cysts. However, there may be some cysts which are not lined by the epithelium and they are known as pseudocysts. So the classification of cysts of the jaws was given by Shears, and according to that classification, the cysts were classified into two broad categories: the epithelial line cyst and the non-epithelial line cyst. In the epithelial line cyst, we have further two subdivisions: developmental origin and inflammatory origin. In the developmental origin, we have odontogenic cysts and non-odontogenic cysts. So today we'll be discussing odontogenic keratocyst, which is a developmental odontogenic cyst, which is an epithelial line cyst. Starting with the components of this cyst, a cyst is formed by the capsule or the wall. The second component is the lumen of the cyst or the cystic cavity. And the third thing is the epithelial lining. If it is a true cyst, there will be an epithelial lining which is supported by the connective tissue wall or the connective tissue capsule. And there is a central lumen or the cystic cavity. So these are the three main components of a cyst. Now starting with the origin of the cyst, when we talk about the origin of cyst, we have reduced enamel epithelium, we have remnants of dental lamina or cell rest of serrae, or we have cell rest of Malassez. So these cysts which take origin from the reduced enamel epithelium are dentigerous cyst and the eruption cyst. Those which originate from cell rest of serrae are odontogenic keratocyst, gingival cyst of newborn adults, glandular odontogenic cyst, lateral periodontal cyst, and the cysts which originate from cell rest of Malassez are the periapical or the radicular cyst and residual cyst. Starting with the introduction of odontogenic keratocyst, this term was first used by Philipson in 1956. Odontogenic keratocyst is known as odontogenic keratocyst because of its origin from the odontogenic apparatus or from the tooth forming apparatus, that is from the cell rest of serrae or the remnants of dental lamina, and keratocyst because this cyst is filled with the keratin flakes. There are keratin in the cystic lumen. So odontogenic keratocyst is being derived from the origin and also from the presence of the keratin in the cystic lumen. Now, when we talk about the OKC, Toller suggested that it is a benign neoplasm rather than a conventional cyst because of its aggressive behavior. So, there was a controversial thought regarding the pathogenesis of OKC, whether they are cysts or they are tumors. So, in 2005, WHO reclassified odontogenic keratocyst into keratocystic odontogenic tumor based on its aggressive clinical behavior, its recurrence, and the mutations in the patch gene. But in 2017, this was not accepted by all. So there were different school of thoughts by different authors because there were not enough reports to justify the genetic and the molecular studies. Also, the mutations which were seen in cases of odontogenic keratocyst were seen in dentigerous cyst and orthokeratinized odontogenic cyst, and the mutation which was seen in cases of OKC was more connected to that of syndromic cases in comparison to the non-syndromic cases. Also, there were a misconception that a tumor can denote either a swelling or a neoplasm. A tumor or a neoplasm cannot give a morphological appearance of a cyst. Also, if a tumor is neoplastic or if a cyst is neoplastic, so it should attain the property of growth autonomy because the neoplastic cells attain the property of autonomy and they fail to resolve even after the removal of stimulus. However, this OKC, once been removed, there are well documented reports that it undergo resolution with decompression. Therefore, it merely shows an aggressive behavior of a cyst, because of which it was further confirmed that odontogenic keratocyst is an aggressive odontogenic cyst, not a tumor. So in 2017, it has been reclassified into the category of cyst. It has its origin from the rest of dental lamina, and it has distinct histological features along with some genetic mutations. Now, starting with the clinical features, when we talk about the age of presentation, odontogenic keratocyst shows bimodal age presentation, which we have already discussed when we discussed the lymphoma. Lymphoma also shows bimodal age presentation. There were two peaks in cases of OKC, one in the second decade, another in the fifth decade. But when we compare the syndromic with the non-syndromic cases, the non-syndromic cases will show two peaks. First peak in the second decade and the second peak in the fifth decade. Whereas the non-syndromic cases, single peak will be there in the age group of 10 to 30 years. When we talk about the gender, usually OKC shows male predilection. Now, when we talk about the site, OKCs are more common in mandible in comparison to the maxilla, and majority of the cases are seen in the ramus third molar area, and which is this location of OKC is attributed to the presence of the basal offshoot or basal hamartia or the remnants of the dental lamina which are being seen in the posterior mandible. And if we talk about the maxilla, then the most common site is the third molar area followed by the cuspid region. Now, when we see the clinical presentation of OKC, it shows pain, swelling, and discharge. Although this lesion shows slow progressive growth, it grows in anterior posterior direction, and because it extends into the medullary cavity, so pathological fracture may be there. But if these cysts are present in the maxilla, then they can be infected and they can be diagnosed at an early stage. So OKC is usually not found in the early diagnosis. It is an incidental finding due to routine radiograph, but in cases of maxilla, diagnosis can be at an earlier age because of infection. And if this cyst enlarges, it displaces the teeth and also it affects the anatomical structures in the vicinity. When we talk about the radiological features, usually it appears as a small round ovoid radiolucent area, but sometimes it can be large, well demarcated radiolucency, which can be unilocular with scalloped borders, or it can be multilocular radiolucency with sclerotic borders. And this scalloping denotes the unequal growth pattern in cases of OKCs. Also, there can be pathological fractures. We can appreciate in this radiograph that there is scalloping as well as multilocular expansion, and also there is destruction of the mandible involving the body and the ramus. Now, when we talk about the radiographic appearance of odontogenic keratocyst, there are different varieties, such as replacemental variety, in which the cyst replaces the normal tooth, envelopmental variety, which mimics to that of dentigerous cyst in the radiographic appearance, which envelopes the impacted tooth, then the extraneous type, which is away from the tooth, and the interradicular, which is between the two roots. When we see the gross appearance, usually there is irregular margins and which show the scalloping, and the scalloped margins in the gross specimen is attributed to the irregular growth which is being seen in the cases of OKCs. Now, when we see the aspiration findings, usually the cystic lumen of the OKC contains cheesy material which is suggestive of keratin. Sometimes there can be straw color fluid also. So the presence of this straw color fluid or thick creamy material into the lumen is attributed to the presence of the keratin flakes into the lumen, and this fluid shows a low soluble protein content when it is compared with the patient's own semen. Now, coming on to the histological appearance, the wall of the OKC is usually thin, and the lining epithelium shows characteristic features such as parakeratinoid surface, which is usually corrugated or wrinkled. The thickness of the epithelium is 6 to 10 cells thick, and the basal layer shows palisaded polarized cells, which shows Thomsturm or picket fence appearance. We can appreciate the histopathological features with the help of this photomicrograph, in which the epithelium is thin and fragile, and the surface shows corrugated wrinkled appearance. Also, since the lining is fragile, there is a separation between the epithelial and the connective tissue. In the high power view, all the features can be appreciated, such as the presence of cystic lumen, the cyst capsule. The epithelial lining is parakeratinoid stratified squamous epithelium, which is 6 to 10 cell thick. The surface shows corrugated in the ringle appearance, and there is polarity of the basal cell layer, which shows palisaded arrangement, and the nucleus are arranged in a picket fence manner. Now, when we talk about the treatment of OKC, usually it should be surgically excised and there is complete eradication. But because the tumor lining is thin and fragile, sometimes the remnants may remain, which can lead to the recurrence. Also, there can be perforation of cortical bone, and which will complicate the total removal. The most important feature of OKC is its recurrence rate. There were different scientists which have documented that recurrences were more frequent in cases of syndromic cases in comparison to the non-syndromic cases. And the keratocyst, if enucleated in one piece, shows less recurrence, whereas in cases where the enucleation takes place in several pieces. And also the OKCs of the mandibulomolar region, angle or ascending ramus had a high recurrence rate, which could be attributed to the presence of these cell rests which are left behind after the surgery. When we talk about the recurrence, if the lesion is multilocular, it will show high recurrence rate in comparison to the unilocular rate. And there was a documented evidence that Brown had found that there is no significant difference in recurrence depending on the treatment, whether it is done through marsupialization, enucleation and primary closure, or enucleation and packing open. So there were different school of thought by different authors. So Brown concluded that the recurrence of the OKC is because of the nature of the lesion, and it is not because of the treatment or because of the appearance. It is because of the presence of the remnants of the dental lamina from which the cyst may develop, and it is not related to the treatment. Also, in cases of OKC, the follow-up is essential for at least 5 years after surgery. And if a patient is found with multiple OKCs, then it should be evaluated medically to rule out the presence of Naevoid basal cell carcinoma syndrome. Now, there are certain reasons which have been documented for the recurrence of OKCs. The first being is the retention of the satellite or the daughter cyst after the treatment. Second, the thin fragile epithelial lining in cases of large cyst. Third is the intrinsic growth potential of the epithelial lining because the cyst has high growth potential. Fourth, any remnant of dental lamina may act as a target for the formation of new keratocyst. Fifth is the basilar cell proliferations of the oral mucosa, which may lead to the recurrence of OKCs. Then the high metabolic activity because the epithelium of the OKC is highly active. Also, the recurrences have been found more in syndromic cases, and the recurrence rates are influenced by the length of the follow-up period, treatment modalities, skill of the surgeon, and size of the lesion. So, if it is not surgically removed or the size of the lesion is large, the lining will be fragile, all these points will lead to the recurrence of OKCs. Now, when we talk about the histopathological variants, OKC shows two kinds of variants, parakeratotic variant and orthokeratotic variant. In parakeratotic variant, there will be parakeratinized stratified squamous surface epithelium, and in orthokeratinized, there will be orthokeratinized epithelium. So, when we compare these two varieties, the parakeratotic variant will show bimodal peak. However, in orthokeratotic, we have mean age in second and third decade. It showed varied distribution in cases of parakeratotic, whereas the orthokeratotic will be usually seen in the posterior mandible, and they usually assume a dentiger relation with the impacted tooth. In the histopathology, the parakeratotic variant will show columnar cuboidal basal cell, which show palisaded polarizing nuclei, and there will be surface corrugation. Whereas in cases of orthokeratotic variant, there will be low cuboid to squamate cells, there will be absence of polarization, and on the surface, there will be leafy squames and loose shreds of orthokeratin. In cases of parakeratotic variant, stratum granulosum is not prominent, whereas in orthokeratinized variant, there will be prominent stratum granulosum. The parakeratotic variant will show high recurrence rate and high mitotic index, whereas the orthokeratotic variety will have less recurrence rate and less mitotic rate. So all over prognosis of orthokeratotic variant and the recurrence is less in cases of orthokeratotic variant, and the parakeratotic variants are aggressive, shows high recurrence, shows high mitotic activity. Now there is a syndrome associated with odontogenic keratocyst, that is Naevoid basal cell carcinoma syndrome. In this syndrome, there are multiple odontogenic keratocysts of the jaw, which can be evident. So if there are multiple OKCs, we should rule out the possibility of the syndrome. There will be presence of bifid ribs. There will be multiple basal cell carcinomas. There will be palmar or plantar pits. Also, there will be bilamellar calcification of the falx cerebri. So we should rule out the possibility of this syndrome if we found multiple OKCs of the jaws. Now to summarize, odontogenic keratocyst is an aggressive odontogenic cyst, and it has been derived from cell rest of dental lamina, that is cell rest of serrae. It showed bimodal age distribution, that is there are two peaks, one in the second decade, another in the fifth decade, usually more common to the males. When we talk about the site, mandible is more commonly involved than maxilla, and in the mandible also Ramer's third molar area. The lesion radiographically can be unilocular or multilocular and shows radiolucent area with the radiosclerotic borders with scalloped margins. When we talk about the cystic fluid is usually straw colored with a thick creamy discharge, and it has low protein content. When we talk about the histopathology, there is corrugated surface epithelium which is parakeratinized. The lining epithelium is 6 to 10 cells thick, and the basal layer show palisaded polarized nuclei with tombstone or picket fence appearance. The cases of OKC shows high recurrence rate, and multiple OKCs are usually associated with Naevoid basal cell carcinoma syndrome. So it's time to attempt the MCQs. Please do the MCQs and write the answers in the comment box. Thank you.